I'm going to hand over to Sean Paul and Aileen, and I'm keen to hear really as they're going to talk us through what it is, that Lean can do, in terms of bringing about process improvement, service improvement, quality improvement, patient safety, while at the same time being person-centered. And I think that's something that the Matter Lean Academy has really focused on and had led really a lot of the thinking in this area. And we're going to have a chat at the end. So Aileen and Sean Paul, over to you.
Thanks very much, Sean. Appreciate that. Okay, hi everybody. Thanks. I'm delighted to be here today with my colleague Aileen. This is a two-hander, very much so. We're going to present to you today about our theory, I suppose, the research we've been carrying out in the area over the last number of years, and also how we put that research into practice. As John said, we'd be delighted to have your feedback and to take some questions and to inform a discussion, and even carry that discussion on after today as part of the Q community, which I know John will talk to you about afterwards. Okay, so basically, in process and quality improvement, we've lots of different methodologies. I mean, sometimes I say it doesn't matter what you call it, as long as it makes a change. So we've the model for improvement, or we've Lean, or we've Six Sigma. We've Lean Six Sigma. We've Agile, which we use a lot in UCD in administrative functions, and then we've got the project manager's book of knowledge, and they're only just some of the, I suppose, from a smorgasbord you could pick to choose. But really, no matter what approach you choose, you're choosing it because you want to make a difference for patients and staff. So, sometimes I say to people, don't worry too much about the terminology, just get it done, and we can call it what we want afterwards. Really, at the end of the day, do we really care, as long as we have a result? So just, I suppose, I know as an audience you'll probably be familiar with, but just from person-centeredness, just to locate us, I suppose, look at McCormick and McCance's definition. It's basically about approaching our practice within our practice settings through forming and fostering healthy relationships between all of us who provide care, and also, obviously, importantly, for our patients and for our patients, and also for their loved ones as well, and looking at them as persons and as individuals with respect for them and their personhood. And then Lean and Six Sigma are really a hybrid of two process improvement methodologies, Lean and Six Sigma, which come from industry, one from Toyota and one from Motorola. And they actually have got quite a strong focus from our own research on the customer, the employee, management support and teamwork. So basically, the research piece of this started about 5 years ago as part of my own PhD, where I was working with the Lean Academy and the team. But what we were interested in was we can get better processes, but we can have a focus on process and on outcomes, but we have to look at the person within the process. And as a colleague of ours you'd be familiar with, I know many of you who work in quality, Mark Grabman would often say, you can't make things better for the patients by making the staff work harder, because then what you're getting is a burnout of staff. And particularly as we're now unfortunately escalating again in COVID, that type of pressure is coming on staff again. So part of my research was asking the question, are there synergies? How does this work? How do you achieve those outcomes, but in a person-centered way? And really, in doing that, one of the first things we did was myself and my supervision team at the time looked at the synergies and divergences between Lean Six Sigma and person-centered improvement. And that was an 18-month review of the literature that literally went through everything from about 2004 to 2018. We kept continually going back and looking again. Found about 4 or 5 papers, so there was very little there actually on it that spoke to Lean and person-centeredness particularly, as opposed to patient-centeredness. So that really enabled us to develop a model of where we thought the synergies and divergences lay from the empirical data. And then we carried out, over about 4 years, we carried out a realist inquiry to identify how Lean Six Sigma contributed to person-centered care and cultures by working with, in a study site, with qualified Lean practitioners who had various levels of experience, who within their individual practice areas were working on a day-to-day basis with all the challenges that you would have clinically or in whatever role you have within the hospital. And we then were able to map what their findings of what worked for them in what circumstances to the model we had earlier developed, synergy and divergence model. And that then fed forward into how we were developing our curricula in UCD, and working with my colleague, Professor Mark McNamara. We started to look at developing a Lean Six Sigma curriculum that spoke to more than outcomes, but also spoke to a view of full systems. So I suppose that's the research arm that was been driving the push to where we are in relation to Lean and Six Sigma. And that has actually evidenced from, I suppose, ground zero to a large number of publications now on Lean and Six Sigma in an Irish context that specifically speak to how we use it in the person-centered ways, or what contributions they make as improvement methodologies to person-centeredness. So that's really great to see as well. That we're starting to develop a body of work, and that's just a scattering of some of the work we've done. So basically, just going back to the synergy and divergence model, what we've done is we've developed this model with myself, Professor John Deering, and Dr. Debbie Baldy in Queen Margaret in Edinburgh. We developed this model. And it looks at the synergies and divergences between Lean and Six Sigma in particular, and person-centered approaches, and then quality, which we felt straddled at the time of the model, and we're continually working to get that, move it with a push towards synergy. And what we're going to do now is Aileen's going to take you through how we have, in our own practice as improvement practitioners, how we have actually put these principles from theory into practice. So Aileen, I might invite you to join there.
Thanks, Sean, and good afternoon, everybody. Yeah, so I suppose I'm going to talk about how that translates into our practice. And as Sean kind of alluded to, and you can see here, this is kind of a nice example of this kind of duality of approach nearly. So what we do is we use the methodology of Lean Six Sigma to the tools and the tool sets, I suppose, to help us unpick and navigate the problem of complexity or whatever we're looking at. But at the same time, there's very much an understanding that this is all about people, and that in order to change anything, in order to bring about any improvement, we need to have input and insight from everybody that's involved in the process in order to bring about or facilitate that change. So this is a nice example. This is some recent work that we've done with the dermatology and plastic surgery team in the Matter. And what we would have done is that we would have carried out a kind of extensive data collection period before this event. This would have been a week-long event, carrying out both kind of quantitative data analysis and also a lot of insight from staff, from patients. We bring all of that together, and through the week with the entire team, we would kind of map that out and look at where the insights are, look at what the data is telling us, and collectively really unpick that and look for improvement opportunities, and kind of analyze that and bring that forward. But what's interesting here is that it's very much about the whole team. It's very much about insights across the board. And that's really important in the first instance to kind of get the perspectives from everybody working in the system and in the service, and to help kind of shape that collective vision for what the future of that service might look like. And it's also really important then to get kind of people bought in as partners and get people involved in the improvement work. Just to give you some examples of some of the kind of work that's emerged from this particular program, working with in particular the dermatology team, we found that there was room for improvement within their referral process. We found that there was quite an imbalance in waiting lists and access for patients into the service. So with the team, we looked at redesigning their triage and referral mechanism to a much more centralized model. So instead of all separate waiting lists, there was a kind of centralized view of that. But I suppose to bring about that change, all of the consultants had to change their practice. Everyone on the admin team had to change their practice. So there had to be this buy-in at the start. So very much kind of getting that insight and getting the kind of input from people early and continuously means that you can kind of progress these changes, and people have kind of a sense of ownership of it, and they see a reason and a purpose for it. So you can very much see how the theme of kind of respect for person and for everyone equally among the team kind of comes through within this kind of work, and voice of the customer, as Sean alluded to, being both staff and patient. Move to the next slide, Sean, please. So this is another example of some work. So this is a project that straddled 4 organizations. It was called the Omega Project. So it was the Mater and rehab sites for patients going out to rehab from the acute hospital. And if the previous example kind of epitomizes that idea of kind of input and bringing everybody together and having that respect for people, this very much does that as well. But I think this one for me was very much about how the voice of the customer actually brings about, you know, understanding into the problem itself. So we had worked with a kind of a multidisciplinary, interdisciplinary team in the Mater, and there was no baseline data on this particular problem when we started the project. So they did a lot of work in trying to understand that, and we got, you know, to a certain level with that kind of internal team in the Mater. But it was really only when we opened that conversation up to across the sites, and we kind of we held a number of collaborative workshops, and we looked to see where were the pain points for everybody in that, you know, team that straddled all of the organizations across the process. Then we really started to make inroads, and we really started to get an insight as to where the problems were. We could see it in multiple and duplicate assessments for the consultants. We could see it in the documentation that actually wasn't used at all, but we understood why, because there wasn't any meaningful information contained on it. So it was very much this kind of collective coming together that gave us this insight into the problem. And I suppose that's one of the points to bring forward, is that without those kind of voice of customer being very much kind of pivotal and at the face of the model, data can tell you so much, but unless you have this, it kind of helps you shape where the project is going. It gives you direction, and kind of you can then understand where to make your intervention. So it kind of crystallizes that, and very much builds relationships as well, which was kind of the foundations of improvement. From the same project, we managed to speak to some patients in the process, and we had known that there were kind of delays along the process. We had heard a lot of, you know, we'd spoken to people and spoken to staff, and that was very much what was coming to the fore. But it took us a while to really kind of get the access to patients, and for them to kind of really kind of put it in their own words where they were feeling the pain. And once we did that, that was another kind of aha moment where we really understood how it was impacting the patient, and how that kind of everything happening last minute or late in the process, the impact that was having, and where we needed to kind of explore interventions and understand the root causes. So it's very much about, you know, how it really brings it to the fore. It really kind of brings it into sharp focus, how the voice of the customer can do that within a kind of a process improvement project. For this project is very much about the Gemba and observational studies, which is at the core of Lean. It's very much at the heart of our practice. And this project was a professional certificate team, so a Greenbelt team that was from Crumlin, and they were looking at their cardiology OPD. And they were looking at this kind of was generated from a patient complaint that there was a child in Kerry that had to travel 5 hours to Crumlin for their outpatient appointment, and they got there, they had to wait an extraordinary amount of time, and with a kind of very small window for visit with the consultant. So some of the Lean tools that you'll see here is the kind of mapping of those patient journeys on the day of the outpatient clinic, and you can see that there was a huge amount of back and forth from the waiting room into the different consult exam rooms, to see the nurse, to see the ECG technician, to see the echo technician, and then the NCHD and consultant. So this was very a kind of one of the we mapped this, and this kind of made the problem very visible, so we could start to see then, and we also kind of carried this out through a number of observations on the day. So that kind of tool and the power of observation is really important here, and it's very much a kind of high challenge, high support, so we can start to see what's happening in the system and where the potential opportunities for improvement are. So what we started,
just to say, what's interesting about this project was that we did voice the customer with 90 parent families, but one of the synergies with person-centeredness is the use of observational studies, as Aileen was saying. But what we did here was we actually asked the families to participate and to map their own journeys. We developed Gemba templates, so the parents 90 parents actually mapped their journeys for us, which was really great, because as I think people were saying earlier in the comments, as John was saying, the one big factor we find in improvement is the time to do it. And the question we often ask people is, how much time do you spend on the process and how much time do you spend in the process? And very few people actually in healthcare currently have discretionary spend to spend on the process or just being in it. So we really worked with parents very collaboratively here to collect that data, which took a lot of the pressure off the staff, if I'm honest. And the parents were really eager and keen to collect the data, because when you explain to them that the impact it would have, well, you get to clinic on time, you get out on time, and you spend more time with your consultant, the parents were just on board. It was really fantastic. Sorry, Aileen, for interrupting.
No, it's great. It's absolutely. Yeah, so it was, as Sean was saying, like through those methods and very kind of, I suppose, innovative ways of trying to collect data, but really bringing people in and really kind of bringing in engagement from both patients and relatives and parents. And we were able to kind of map that out. And then we could start to kind of unpick that a little bit and kind of look to see, okay, we know that there's lots of back and forth going on here. And as I say, very much in that kind of person-centered approach of high challenge, high support, we can start to ask questions about that. And we start to look with the team to see, well, you know, are all of those kind of stop-offs or kind of points at bus stops, I suppose, necessary on the journey. So what we found was that when we asked the question of does every patient need to go to see the nurse, that the team said, yeah, because, you know, they need to kind of have their weight and their kind of observations carried out at the start of clinic. And we said, well, look, could we put a weight, you know, a kind of weighing scales in each of the consult exam rooms, and that might, you know, kind of mitigate that. And they said, yeah, that's definitely a potential. Does every child, did they all need ECG? Yes, they did. Did they all need echo? No, that's just, and we kind of said, well, why? And they just kind of said, well, that's current practice. That's kind of how we do it around here. But that they really started rethinking it. So I suppose ultimately they were able to kind of look at a way of triaging clinic before the actual day of clinic, so they could start to nearly direct patients and kind of create pathways out of that, so that everyone didn't have to, you know, necessarily take every stop. And that the impact there was huge in that they were able to spend a lot more protected time with the caregiver, and we'll talk about that in a couple of slides. But by this kind of pre-planning and plotting out of pathways and understanding of different needs, they were able to really kind of, for the complex patients that needed it, they were able to spend more time with the consultants, and the patients that didn't necessarily need to, you know, have an echo done each time, that was kind of removed from their visit. And then another project which is really interesting and a really nice project was, this was another professional certificate project, an interdisciplinary team of, there was an orthogeriatrician, an AMP, physio leading out on this team. And this was looking at the hip fracture pathway, and particularly around the time to surgery for the patient. So this was a really complex problem for them to get their heads around, and they used various different means and kind of data and tools to try and this is very much trying to put together a jigsaw. And that's often what we find, is that, you know, you get a certain amount of information from a certain source, voice of customer gives you another layer, and you kind of piece it all together, and you look to see where can we make the improvement. But they found, through mapping, they found that there was it was literally only, there was 27% of patients that were getting to surgery within 48 hours, which was the national KPI. And ultimately what they did, they looked to see how could they start the processes earlier, so that when a patient came into ED, that they that decision to admit, so the CNM and ED would typically know that this patient had a hip fracture, and you could get those other processes started earlier in terms of decision to admit and pre-op assessment. But the really interesting thing here, they also found that from a quality perspective, that there was only 7% of patients that were receiving the nerve block on this pathway. So the analgesia, you know, in hip fracture is obviously hugely critical for patients, that pain relief. And they found that in this case, there were only 7% of patients were receiving that. Started to look, and they started to talk with their colleagues, and they you know, came up with some ideas, and some of those ideas were around you know, the kind of delivery of analgesia, and they started talking to the anaesthetic team, and they said, well, look, we're in theatre, we can't be in the emergency department, but could we look at this a bit differently? And the A&Ps said, look, we could be trained up on the administration of the nerve block, and similarly the orthogeriatric team. And this is a lovely example of the kind of upskilling and kind of cross-fertilization between teams. So that is what they did. The anaesthetists trained the A&Ps to be able to deliver this analgesia in the emergency department. So really, really effective in terms for the patient. So that went the percentage of patients that received the nerve block went up to over 60% after this project. But for those A&Ps and for that kind of upskilling, there's this huge kind of staff empowerment there of, you know, kind of working within their licensure, really kind of being able to progress on their skill set. So a really nice example of that in that kind of interdisciplinary team.
So this slide here speaks to, I suppose, one of the key things we looked at where we're starting to talk about, I suppose, some differences between Lean Six Sigma and person-centered approaches. And this slide here really speaks to it quite well. I think I've borrowed this again from Mark Grabban with his permission, but this really talks about how KPIs are obviously really important because they tell us how we're performing, they set bars, they let us know what we're doing, and they give us feedback. But I think Mark talks about, and what we found in the literature as well, was how demoralizing incorrect use of metrics can be on staff on the ground. Going back to if you're particularly busy, so like for example, if you collect data on the day, I know myself when I worked in quality, going up to a ward one day to a CNM to do an audit, and she said to me, I have 2 people off sick today, I have a staff nurse from another ward, and I have 1 HCA, and the ward is absolutely chock-a-block. Could you come back another day? So I had to really divorce, I suppose, the tick box from I need to get it done today to I'll come back on a day, because it's not an accurate capture when we're not looking at workforce profiling, etc. But I think one of the things that's key is that we have to be sure that we let our metrics guide best practice, but not dictate practice in such a way that it clashes with the first principles of people's ability to carry out their job, to people's professional status, first of all. And secondly, in relation to core values, there can be a difference between approaches to process improvement with their view of value in a very narrow form as the value you add to a process, or, you know, this was valuable, as opposed to people's core values. And most substantive and sustainable change is shown to come on board when you pull from people initially, and by listening to their voice and spending a lot of time actually engaging with them, but actually respecting what they value and understanding. And actually, we've just published a paper this week in relation to quality care metrics in nursing and midwifery. And one of the key findings we had in that paper, and this is a national study, was that, you know, one of our key findings was, you know, respect for nurses and midwives' values and beliefs. So, you know, when we go into an organization to deploy a new way of collecting data or a new set of guidelines, that we're listening to the people who work in the area, that know the culture, that know the organization, because that lived experience and their experience is valid, and their values are valid, and it's recognizing those in any way is so important for us to be able to actually instigate change, or to actually show respect for those people as well. Another difference we talk about is if you look at the literature on process improvement, generally that's not healthcare based, that's based, say, in motor industry or in industry generally. It talks about standardization, and it talks about, you know, if you look at the literature, it says remove unwanted variation in a process. However, we would look at that using Six Sigma, removing, like, instead of 15 ways to schedule a patient, we might look at, you know, getting that down to 2 ways so anybody can do it and it's user friendly. However, a really key point is that we can't afford to in healthcare to talk about removing variation. We have to talk about move to a mindset of removing unwanted variation, because variation, not all variation is bad. You know, variation between specialties, variation between how we work in different departments or different hospitals, depending where you're working, that's all good variation because it's tailored to more holistic patient care, to the individual patient. So we just really need to be careful that when we talk about variation, that we don't see all variation as bad. Variation is not bad. It depends on how you view it and what its purpose is. Just to, I suppose, come back again to values. It's really that key point of value versus values. And you can only really have a person-centered improvement when you take on board people's values when you start out. We can, unfortunately, due to, again, and I think a lot of you were saying at the beginning in the comments, due to pressure of time, we can sometimes play lip service to we've engaged with people, we've engaged with patients. We did a survey, tick, 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 which is final surveys, and they give us lots of information and they give people voices. But it's actually having that rich data of actually engaging with them, talking to them, interviewing them, getting data back. And funnily enough, on a project I'm working on currently with an ophthalmology team, we did 35 patient interviews of people who'd been through a particular pathway. And whatever the patient said, first of all, they all said the staff were fantastic, which patients, regardless of the system, tend to be effusive about staff. But one thing that they spoke about that came up the whole time, and one of the key themes was time. Time to get information, timely information, time to preoperative assessment, time to surgery, time to the OPD, time waiting in clinic. And the last big time factor was time they actually spend with their consultant when they get to clinic. So the patients were all about time, not just us, which is one of the definitions, and it's not a textbook definition anywhere you'll find, but this is a definition that myself and Aileen use in our improvement is, forgetting about the textbook, we say that improvement is about giving you the time to do the things you have to do in the time you have to do them. So that for a staff member, your values might be doing your job well, but actually getting home to your family on time. So if you finish at 5, that you get off at 5. So, but can you get all your work done in that time period? So it's looking at our time, removing the non-value add to give us the time to actually do the job we want to do to our satisfaction in that time. So the values is a really important piece. Just to say as well, pardon me, just to say as well, if we bring all these together, there are a number of themes that come out, and I've just put these into a word cloud here. Whatever improvement we do, we have to be aware of things like overburden, not making people work harder than they're already working, to look at how we can lean the system, to use improvement to make things better for staff as well as patients, to take on board people's values, to know when there's the Deming's 94-6 rule, and it applies to all service industry, and I've seen it in over 200 process improvement projects now. 94% of problems are down to the system and 6% are human error, and human error will always occur. So if we think of that 94-6 rule, I think it's really important that when things go wrong, we don't lapse into the blame culture of it's this nurse's fault, it's the porter's fault, it's the doctor's fault, it's whoever's fault. We always like to have somebody, even myself, when things go wrong, oh my God, we have to assign it to somebody. But actually thinking, well, where is actually the system failing? Where are the problems with the processes we're working in? And that is a far more person-centered approach to improvement. And sorry if we ran a bit over, guys. I'm really sorry about that. But thank you very much. And Aileen, do you want to?
Thanks, guys. No, I think we can open it up to John and the floor then.
Thanks very much, folks.
Thank you, guys.
Look forward to talking to you.
Well, thank you so much, folks. That was really, really wonderful, and thank you for such a big picture view of lean. But I think if anybody was expecting this was just going to be a technical kind of exposition of lean, I think you've showed us that it's so much more than that, and there's so much in that. I suppose I'm thinking of the value, obviously, which is at the center of lean, and the things provide value, but that's based on values, and I think also being valued. I think and maybe that's my first question. We'll take some questions from the chat if they come in, but I think I've seen this shift where we're no longer ashamed, I think, to talk about that looking after the needs of staff, framed from the point of view that staff want to look after patients and look after the healthcare system, but we have two duties, which we need to meet, the needs of the patient and the needs of staff. And I think that's become much stronger in all quality improvement and recognized, from the point of view that staff want to do good work. And I just wonder what your thoughts are on that we're able to talk about improving the work for the staff as much as we are for the patients. Yeah.
Well, interestingly, we've just published, actually, we're publishing it this week. We're just publishing a paper. We published one the week before last in relation to operating. My background is in the operating department. So I was a theatre manager, worked in surgery my whole life as a nurse. But we published 2 papers. One was just published and one is out this week. And in that we spoke about obviously releasing nursing time to care, because one area that's really short of nurses and seems to be historical is theatre nursing, because at the moment it's really they're like gold dust. And I know myself when I was trying to recruit nurses back in the day for theatre. But interestingly, in that project, when we had a goal it started off as a procurement project that was looking at cost savings, but then we found that if we were going to look at procurement and cost savings, actually one of the key things was going to be the staff. And then we found that by actually making those procurement savings, we could actually release nursing time to care. But moving that forward more, one of the key questions in improvement is, if you release time, what do you do with it? And what I really liked about that team I was working with was that they said very early on, well, actually, one of our things we'll do at the time is actually make sure that all our nurses get a lunch break. Because any of you who've worked in operating theatres will know that when you actually go to, you're told you have a half an hour for lunch, and you just sit down and they go, "Oh, Sean, your patient's on the table." And there's no such thing as a lunch break in theatre, really. Nobody, because when the patient's ready, you go. And that's the same everywhere. So like, I thought that was really a nice turn of the focus of, yeah, actually, even one of the changes could be making sure people just actually get their lunch. And that is an improvement. Now, some people might say, well, that doesn't impact the patient, but actually a well-fed, hydrated staff nurse scrubbing for a 5-hour case is going to be a lot more attentive, So to me, those type of things are small, but they're big at the same time,
Yeah, absolutely. And I think our appreciation more of human factors now, and like you said, the needs, the physiological needs and the psychological needs of staff to be able to look after patients, I think, and so making sure that those needs are met so that they can do the job that they're supposed to do.
Yeah, very much so, John. I would agree. And I think, it's kind of nearly about understanding those needs to help us design systems that support people to do their work. I think that's kind of, for me, I really think that unless that you're kind of trying to make environments and systems and processes easier, more efficient for people, more intuitive, that, I think that's kind of the key to lasting change, I think.
Super. A nice comment there from Tibbs Pereira in Patients for Patient Safety, from Patients for Patient Safety, just saying some great work there. And his question is, how are the learnings shared systematically across the health service? So what does the Matter Academy do to share all this learning?
So that's a really good question. I'm glad you asked that. So we run, first of all, we have an annual symposium. I know, John, you're a good supporter of us there. We have a symposium every year with UCD and the Matter Academy, and we bring international speakers and national speakers who work on quality improvement over. Unfortunately, this year it was on Zoom, but we hope to be back to normal next year. And we will also then from around the country, process improvers are invited to speak from around the country nationally, pardon me, and they come and they speak to what they're doing, their work as well. We also then, pardon me, we also then encourage all of our students to produce scientific posters. So we would have about 200 projects since inception now that nationally we're working on, and they would all have a scientific poster attached to them, and they're out there and we encourage people to present them. And finally, from I suppose year zero, when we started off, there was some small number of case studies in Ireland of Lean Six Sigma use. We now have we are moving into high numbers now in peer-reviewed publications. But what's nice is we have, I'll be honest with you, when we started, I used to give French, Canadian and English case studies, and now actually I can do an entire class with Irish case studies that are contextualized for Ireland. So we are definitely trying to share. But I think another key point that I'd like to say is that if you see an improvement somewhere, so for example, this network, and that's why I think the Q network is really important as well, and any network that can share quality improvement, because we had a team in the Mater who were working on blood contamination rates in the emergency department. And 6 months before, I'd worked with a team in Sligo who actually had solved the problem. So rather than say, do it again, I just hooked up the team in Sligo with the team in the Mater, and they just implemented it quite quickly. So it didn't have to become a QI project, it became a just do it. And I think if we need to, as improvers, and I know all of you here today will be working in improvement or working with improvement, that we need to coalesce as a community to have that sharing of knowledge, because there's no point in doing something if you're not sharing best practice. So I think that's a really good question. I hope I haven't.
Interesting there, Sean, as well. I just see Charlotte coming in on the chat, Charlotte from Sligo. So
Yeah, great.
it's another way in terms of dissemination, or kind of spreading the word and the work from the kind of white belts that we do, which is kind of like that first introductory 1-day session, and then students can go on to do the 6-month green belt program, and then follow on from that a kind of black belt. And we've got a nice model working whereby the two, Noreen and Charlotte in Sligo, for instance, that they now teach the white belt down in Sligo. So there's kind of a nice model for kind of a network, and for just kind of building capacity within the other organizations. So yeah, we're kind of very happy for that to spread in that way.
Yeah, and it's great because I mean, obviously, it is the Matter Lean Academy, but you're not just in the Matter. Obviously, you get to work with people all over the country, and I suppose one of the things I'm interested in is you've got a good relationship with UCD, and I think one of the nice things that you've done is you've given, I suppose, an academic side as well to quality improvement and service improvement, and how has that worked for you? Because I think that's an important thing that we should be doing. People like to have an academic edge to their work, and I think it brings a richness in terms of the rigor and again, in terms of Tibbs's question, sharing the learning. Has that been a real strength to the program?
I think so. I think since I moved to UCD, definitely I find I suppose the first thing is what's called, people probably say, why didn't you do a PhD from my point of view years ago? But actually, I never really found anything I was interested in. But then I was practicing, I suppose, process improvement, but actually thinking something was missing. And basically what I found was missing for myself was the person. So I suppose the UCD connection, because I'm lecturing on the programs and with the master's students, well, it gives me a chance to bring it all together and to really, as you can see, what we're working on in theory, implemented in practice. Back in the day, theory for practice, from practice. So, and we feed back, we feed forward and backwards. So it's nice. It's a nice loop learning, I suppose. We're feeding forward and feeding back the whole time. Definitely, it has really been important, I think, for me. And I'm not wearing a guaranteed Irish flag here or anything, but I think what's been really, and the thing I'm most proud of, I suppose, working with the team in the Matter, is that we've developed something that's contextualized for an Irish context. Because a lot of people will say to you, oh yeah, this worked really well here, but in another country, which is fine, and we can take learning from that and we can apply it. But even within hospitals, even within wards, there's what works on ward A will not work on ward B. So it's really that understanding of it's not a one size fits all. We can take what we can from theory and from the empirical literature, and we can learn, but we then have to see, well, actually, how does that work for us in our context, or does it work? And I think that's where we've been able to really push the boundaries, I think, in the research pieces, to sort of look at how it works. And I suppose I'm a realist researcher, so it's understanding how it works, not just did it work, which is the question. That did that improvement work? Yes. Why did it work? And if we can continue to focus on why and how it works, that I think will give us a good understanding. And I think the partnership we have with the Lean Academy, the team there, we're again, as individuals, going back to individuals, we my colleague Una, Aileen, Vanessa, and Michelle, Kieran, Siobhan, all of us who work together in the team, in the Matter, one person who left the Matter, who was a coup there and went to work in another hospital, she said when she was leaving, she goes, that's the most fun department. It's great. No matter how busy it is, even when we were redeployed during COVID, we'd always have a laugh. And I think that type of energy that we pull from each other is synergistic as well. And it sort of underpins the ability for all of us to do the research, to do the practical work.
I think it's important as well, just in terms of the kind of building of culture. So I think that it was really interesting for me, because I had initially been part of the Matter when they had kind of started out with some initial lean projects, and that was kind of on move to the new build, and really I went and worked in different consultancy firms, and that was kind of the time of the establishment of the Lean Academy, and there was a kind of a critical mass of people that were trained within the fundamentals, and then went on, you know, kind of within the organization, and kind of became more senior in the organization. And so I remember coming back and just being really struck by this huge changed atmosphere, changed kind of sense of kind of optimism within the organization, that people really felt like they could kind of get involved in change, that they could make a difference, and that was really something that was really tangible. And I think that the matter of kind of embraced that, and in other organizations that we've worked with now as well. But it's that kind of idea of helping to build a culture, helping to build capacity, kind of looking at a learning organization and looking at kind of making that an attractive place to work. So it's kind of a really nice momentum is built there, you know, kind of yeah, it tends to grow.
Yeah, super. Great. It's fantastic work. Where can people find you, folks? Do you have a website? I'm sure I see one link there in the chat, but we should probably, you know, if people are interested in learning more, doing more.
Our website, John, is unfortunately down at the moment.
Is it? Okay, okay. Well, we'll
yeah, unfortunately.
We're in mid rebuild.
Yeah, after, I suppose, after the hack and everything, it wasn't a priority relaunch. We're focusing on clinical systems, but yeah, it's being rebuilt at the moment. So,
but you're on Twitter as well, aren't you? You've
yes,
got
yeah.
so people might find out more there. You know, again, there are some wonderful resources online. I mean, I think we share a great appreciation of Mark Rabin and the Lean Blog podcast. I must say, I've learned so much from that, and there are so many there that cover so many aspects of how lean affects person-centered care or safety, and you know, I love, again, a lot of, even when he talks about industry, it's about the principles of, you know, respect for others and understanding the work, you know, that they're the core principles. And any other good resources you'd guide people to?
Well, we have a if you were to follow myself or Aileen on Twitter, we have we run, as well as the symposium, we run 4 masterclass a year with and they could be like, for example, we have Mark Rabin in Dublin doing just before COVID, doing a workshop for 50 people. We were doing Deming's B game and stuff like that. So he's coming over again next year, but we sort of limit the numbers to those. But if anybody's interested, everything we run, then UCD run a number of mass classes as well. So everything's basically free. So, but it's first come, first serve, and unless it's online with COVID. So there's lots of those. Also, if you go to I think you've put up the link for the UCD Iris page. It's all the publications that are dealing with person-centeredness, process improvement, quality, and co-lead and co-design. They're all there. There's loads of publications, all Irish, obviously with international outface, but like, so we have a good few resources on the website there, the Iris, UCD Iris as well. Until our own website gets back up and running, you could definitely go there.
Yeah. Well, look, thank you both so much. It's really it's wonderful work, and I think, you know, not only is it making patients' lives better, but like you said, you know, it's improving the lot of ourselves, of staff, and we're contributing on a world level, I think, to the literature and you know, the learning that is helping people around the world to improve quality and safety. So well done.
Thanks very much for having me.
I'm going to give a quick just plug there to the Q Ireland network map, where there's a link in the chat there as well, and you can join the map by visiting HSE website and then set your unique kind of link there. And like Sean Paul and Aileen were saying, you know, this is so important to connect people, and I think, you know, no element of quality improvement is an island. I think everything links together, and there's great opportunity, I think, for everybody to learn. All of the disciplines are so interlinked and have the benefit, I think, of you know, getting insights out of other approaches and other ways of looking at the world. So for those of you who are in Q, keep an eye on things, and really a shout out to anybody who's not in Q to please think about joining, and you can apply on the website. And if you have any queries there, Caroline Lennon-Nally, our colleague, can be contacted, and she'll tell you some other things about Q. And so that kind of brings us to the end of today. Thank you, Sean Paul and Aileen. We have our next QPS Talk Time is on the 30th of November, when we are going to, again, another linked topic. We're going to be talking to the authors of the new Introduction to Human Factors for Healthcare Workers, which has been commissioned by the HSE, Dr. Paul O'Connor and Dr. Angela O'Dea, and we'll have a really, I'm sure, interesting chat with them in 2 weeks' time. So look forward to you joining us for that. And for now, thank you very much. You'll get your little quick pop-up feedback as you sign off, and I'd really appreciate if you could just even give us a few comments so that we can know where we're going and what we can do to improve. So thank you all very much. Thank you to our guests, and thanks to Maureen and Noemi and Stephanie for all the work in the background, and we'll see you in a couple of weeks.
Thank you, Sean.
Thanks very much.